Okay, time to dive deep. You've brought us a specific task today, taking your MSRA revision notes on acute bacterial sinusitis.
Yep, and the goal is to turn them into a really high-yield, easy-to-remember breakdown.
Exactly. This isn't just reading your notes to you, it's about digging into them, really pulling out the absolute essential points.
Making them stick for your revision. Think of this as like a focus session. We're extracting those crucial insights that might be kind of buried in the detail.
Right. We'll follow the structure you've laid out, starting with the basics.
Definition, causes.
All the way through to management, complications, highlighting what's really key for recall.
So our mission really is to cut through the noise, give you the key facts, the timings, the causes, the management principles your notes emphasize.
And hopefully by the end, this topic, which can feel a bit dense, will seem, clearer, more organized, ready for revision.
Okay, so let's get straight into it. The core definition from your material. What exactly is acute bacterial sinusitis, according to these notes?
Right at the start, the notes make a big point. It's an infection of the paranasal sinuses that happens after a viral upper respiratory infection.
Ah, that sequence is vital. Viral illness first.
Then the bacterial colonization kind of takes hold.
Got it. And the notes specify the actual sinuses involved?
They do. Frontal, maxillary, sphenoidal, and ethmoidal. They even mention, which is interesting, how they develop from nasal mucosa diverticula.
Oh, okay. Like little outpouches that expand.
Yeah, especially during childhood growth spurts, apparently. A nice bit of context.
And they clarify rhinosinusitis, too, I see.
Yes, often used interchangeably. Basically means inflammation of the sinus membrane. And usually the nasal mucosa is involved too. It's inflammation and infection.
One of the first, really critical distinctions your notes make is about duration. This seems essential for diagnosis.
Absolutely. They break it down quite clearly. Acute, 7 to 30 days.
Okay.
Subacute, 4 to 12 weeks.
Right.
Recurring is quite specific, more than 3 acute episodes a year, each lasting at least 10 days, but with symptom-free gaps between them.
Okay, that's very specific. And chronic.
Chronic is just over 90 days, with or without acute flare-ups.
That timing, that seems like the absolute key takeaway from this section for diagnosis, doesn't it?
Totally. The notes really, really stress this. A viral thing usually clears up, within 10 days.
Right.
So the red flag for bacteria is if symptoms either worsen after maybe 5 days or so, or, crucially, they just persist for more than 10 days. That 10-day number is the one to burn into your memory for revision.
Absolutely. That duration point is super high yield, a real diagnostic clue. Okay, so we know what it is, how duration helps classify it, but why does it happen? Let's look at the etiology, the causes, and the risk factors your notes cover.
So the notes list the suspects first, the common bacteria when this kicks in.
Go on.
Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. Those are the big three.
The main players. Got it. And what sort of sets the stage for these bacteria to cause problems? Your notes mention predisposing factors, especially for kids.
Yeah, and no surprise, the main trigger is that initial viral upper respiratory infection. That's what starts it all.
Makes sense.
But also things like allergic rhinitis, anything causing an anatomic obstruction, mucosal irritants, even sudden atmospheric pressure changes, like flying or diving maybe.
Could be. And thinking more broadly about who's actually at risk, your notes have a pretty comprehensive list.
They do. Things like structural abnormalities again, allergies, nasal polyps, a deviated septum comes up.
Okay. And underlying health conditions.
Yep. Immunodeficiency, cystic fibrosis, or smoking. Big ones.
And environmental stuff, like pollution.
Yeah, frequent exposure to irritants or pollutants, and also recent local issues, nasal obstruction, other local infections, or even recent dental work.
Ah, the dental work connection,
Yeah.
especially for the maxillary sinus, right? Makes sense.
Totally. Don't forget activities like swimming and diving, they're on the list too.
Right. And conditions that just generally promote inflammation.
Like those upper respiratory infections we mentioned, allergies again, asthma. The notes actually list anatomical variations in nasal polyps, again, under mechanical factors. They must be really important.
Seems so. And obviously, being immunocompromised is a significant risk factor.
Definitely.
Your notes also flag some rarer but important associations, things you might not immediately think of.
Yes, like cystic fibrosis, neoplasia, sarcoidosis, GPA, which is granulomatosis with polyangiitis,
Good to clarify that acronym.
and immotal cilia syndrome.
And they specifically mention Sam Conster's triad under these rare causes too.
Ah, yes, Sam Conster's triad. What is that again, according to the notes?
So the notes outline it as the combination of aspirin sensitivity, rhinitis, and asthma. It's linked to a specific type of inflammation.
They can lead to polyps and chronic sinus issues.
Right, exactly. And finally, prior sinus surgery is also listed, probably because it changes the anatomy.
Okay, so we've got the definition, the types based on time, who gets it and why. But how does that initial viral cold actually become a bacterial infection? Your notes walk through the pathophysiology pretty clearly.
Yeah, this is where the sequence becomes like a little story. It starts, just like the definition said, with a viral upper respiratory tract infection, a common cold.
Which naturally causes inflammation and edema swelling in the lining of the nose and sinuses.
Exactly. And that inflammation changes the whole environment inside the sinuses. Crucially, it creates conditions that let bacteria start to colonize.
So the notes are saying the bacteria aren't the first problem, they just take advantage.
Pretty much. They move in once the viruses, rough the place up a bit.
And that inflammation also ramps up mucus production, right? Makes it go into overdrive.
Precisely. Now here's the critical step, the bottleneck. That combination of inflammation, swelling, and all that extra mucus leads to obstruction. It blocks the little drainage pathways, the ostia.
That connect the sinuses to the nasal cavity. Okay, so they get blocked.
Yep. And the blocked drainage traps all that mucus, along with the bacteria that have moved in, inside the sinus cavity.
And that stagnant, nutrient-rich gunk is where the bacteria properly multiply and cause the actual bacterial infection.
Exactly. It's a clear chain reaction. Virus, inflammation, swelling, agar block drainage, bacterial growth.
Understanding that sequence, virus, blockage, bacteria helps make sense of the symptoms and why that timing is so darn important.
Definitely. Now, because those early symptoms can mimic other things, your notes wisely include a list for differential diagnosis.
Right. This is the what else could it be list. Important stuff. The number one confusion is obviously viral sinusitis itself, that initial phase.
For sure. What else?
Allergic rhinitis, non-allergic rhinitis, nasal polyps, dental infections you mentioned, the tooth pain link.
Yeah, radiating pain.
Migraines, the simple common cold, and adenoiditis, which the notes flag, especially in children.
And again, that key timing point viral, usually done by 10 days, helps you tell it apart from bacterial.
Right. And you might look for other clues, like itchiness and clear discharge for allergies, or where the pain is for dental issues. Adenoiditis symptoms might overlap in kids, though.
Good points. Okay, moving on to epidemiology. Your notes give us some UK context.
Yeah, they say the exact prevalence isn't established, but it's common, especially in winter and in people who get lots of respiratory infections or already have chronic rhinosinusitis.
And the numbers suggest it's pretty common in adults.
Yep, 6–15% of adults. Children get it less often, mainly because their sinuses aren't fully formed.
Makes sense.
But it still happens. Notes say about 6–7% of children with respiratory symptoms show features of it.
Okay, so we know who's getting it when. Now, the really practical bit. What does it actually look like when a patient walks in? Let's detail the clinical features, symptoms, and assessment findings according to your notes.
The classic symptoms listed are facial pain or pressure right over the affected sinus, nasal congestion, obviously, and importantly, purulent nasal discharge.
The thick, colored stuff.
Oh, yeah. Also common are headache, fever, pyrexia, fatigue, a reduced sense of smell, cough, sore throat, maybe some ear fullness, and even halitosis, bad breath.
And there it is again, that crucial timing point, hammered home.
Yep. Symptoms lasting more than 10 days or worsening after that initial viral phase are the key clinical flags in your notes to suspect bacteria.
Got it. And for the clinical assessment itself, what do the notes suggest doing?
Well, they mentioned palpating the sinuses for tenderness, pressing gently over the frontal, maxillary, ethmoidal areas.
Okay.
But interestingly, they also say that older techniques like percussion, tapping, or transillumination, shining a light, have pretty limited usefulness nowadays.
Right, so it really comes down to the history and the symptom pattern, especially that timing.
Exactly. That seems to be the powerhouse for diagnosis. The notes summarize the typical patient. Someone whose cold just isn't getting better, seemed viral at first, but it's now past 10 days or actually getting worse.
And key signs on examination might be that tenderness over the sinus, maybe a fever, seeing that purulent discharge, maybe they mentioned not smelling things properly.
And you might see some redness and swelling inside the nose, too.
Okay. Given that strong emphasis on clinical diagnosis, what about investigations? Are scans and tests needed routinely?
This is another really high-yield point from your notes. Routine investigations are usually unnecessary for diagnosis.
Okay, good to know.
Acute bacterial sinusitis is primarily diagnosed clinically, based on those symptoms and that timing threshold we keep talking about.
So when would you consider imaging?
Your notes specify it's reserved for when symptoms are persisting despite treatment, or importantly, if you suspect complications.
Ah, right, if things aren't going as expected or seem more serious.
And they really underline when urgent evaluation and imaging are needed. If the patient has severe symptoms or clear signs suggesting a complication is developing, don't hang about if you suspect something serious.
Makes sense. So, just to reiterate, the notes list the core clinical diagnostic criteria as
Facial discomfort or pain, nasal symptoms like obstruction or discharge, and decreased sense of smell. Plus, those other supporting symptoms we mentioned.
and things like blood tests, ESR, CRP, or even MRI.
Rarely needed, according to the notes, really only if there's major diagnostic uncertainty or you're actively investigating for complications. The main message is trust the clinical picture unless red flags appear.
Which brings us nicely to management. How do we treat this based on that stepped approach in your notes? They split it into symptomatic relief and prescribing, right?
Correct. Starting with symptomatic relief and non-prescribing measures. The notes recommend standard stuff. Analgesics for pain relief.
Paracetamol, ibuprofen.
Yeah. Saline nasal irrigation, rinsing out the nose, helps clear mucus. And intranasal corticosteroids.
Okay, the steroid sprays, when are they suggested?
Specifically if symptoms persist over 10 days. Again, tying into that timing for suspected bacterial involvement.
Interesting. What about decongestants?
They're mentioned intranasal and topical ones, but the notes caution there's limited evidence and they should only be used short term, like up to a week max.
Okay, so the initial approach really is just observation and supportive care for that first 10 days.
Pretty much. Reassurance, pain relief, saline rinses, warm face packs, fluids, rest, all that good stuff. Mucolytics are also mentioned as potentially helpful.
So lots you can do before reaching for antibiotics. When do we consider prescribing management, specifically antibiotics?
Your notes are very clear here. Antibiotics are not recommended if symptoms have lasted less than 10 days.
Okay, the 10-day rule again?
Yep. They are considered if symptoms worsen significantly, if they persist beyond 10 days, or sometimes for younger patients, although watchful waiting might still be preferred unless they're quite unwell.
And for specific groups, like immunocompromised.
Yes, also for immunocompromised or other high-risk individuals. They often need individualized treatment, potentially antibiotics sooner.
Got it. So assuming antibiotics are indicated based on timing or severity, what are the first-line choices listed in the notes, following NICE guidance?
Phenoxymethylpenicillin or doxycycline. Those are the go-to options.
Okay, and what if it's a more severe case or one of those high-risk patients?
In those situations, the notes say amoxicillin clavulinate is preferred, co-amoxiclav.
Right, and if someone has a penicillin allergy?
Then doxycycline is listed as the alternative.
Okay, and how long would a typical course be?
Usually around 5 to 7 days, according to the notes, but you'd adjust based on how the patient responds.
And if they don't respond, say you review them after 7 days and they're not getting better, what do the notes suggest then?
Good question. The notes mention reviewing their response, checking if they've actually been taking the tablet's compliance issues.
Always worth asking.
Definitely.
Yeah.
Then maybe adjusting the dose or considering a second-line antibiotic. And this might be a point where imaging could be useful just to confirm the diagnosis if you're starting to doubt it.
Okay. The notes also mention something about high-dose nasal corticosteroids again.
Yes, considering those, if symptoms haven't improved after 10 days, even without antibiotics. And they also bring up the strategy of using a deferred antibiotic prescription.
Ah, the delayed script. That's quite common now, isn't it?
Seems so. Writing the prescription but telling the patient, only fill this if you're not better by day X or if you get worse, aligns with that watchful waiting idea.
And obviously, referral criteria exist if things get really severe or complications are suspected.
Absolutely. Now, any specific groups needing different antibiotic choices, like kids or pregnant women?
Yes, and your notes highlight two crucial ones. For children, doxycycline is contraindicated. Very important to remember that.
Right. Can affect teeth development.
Exactly. And for pregnant or breastfeeding mothers who need an antibiotic, the notes recommend erythromycin.
Good specific points to remember. Okay, let's zoom out a bit, like the prognosis. What's the general outlook for patients?
Your notes state that with the right treatment, the prognosis for acute bacterial sinusitis is generally excellent. Most people get better without long-term issues.
And how quickly might they feel an improvement once they start therapy?
Symptomatic improvement usually kicks in within a few days of starting treatment, especially if antibiotics are given when they're actually needed. But there's but, isn't there?
There is. Your notes add that crucial caveat. While it's usually good, complications can happen if the infection spreads or maybe becomes chronic.
And interestingly, the notes also point out that symptoms might actually resolve completely within 2–3 weeks, even without antibiotic treatment in many cases.
Which really reinforces why we have that initial observation period for milder cases, doesn't it? Antibiotics can speed things up, but aren't always essential.
Exactly. Which leads us neatly into those rare but potentially very serious complications. Your notes emphasize these are uncommon but need quick recognition.
Yeah, hearing the names definitely makes you pay attention. Orbital cellulitis and periorbital cellulitis, infections spreading into the eye socket area.
Yes, very serious. And potentially even more concerning are intracranial infections, think meningitis, or even a brain abscess.
Wow.
Also listed are sinus abscess formation, like in the bone itself, septic cavernous sinus thrombosis, a dangerous blood clot in a key vein near the brain,
Scary stuff.
and osteomyelitis of the frontal bone, so an infection of the actual forehead bone.
Jeez. Those sound like situations where things have gone really wrong. And your notes mention these are actually more common in children.
They do, which just underscores the point stressed throughout your notes. Prompt diagnosis and the right management, especially spotting those red flags early, are vital to prevent these rare but potentially devastating outcomes.
And the notes also mention cutaneous fistula formation and chronic sinusitis as other less common potential negative outcomes.
Right.
Okay, wow. We've really walked through your notes on acute bacterial sinusitis quite thoroughly there. We hit every section you outlined, from the basic definition and that crucial timing.
Through the causes, the pathophysiology, how it actually happens step by step.
What else it might be confused with, who gets it, what it looks like, when to do tests, or usually when not to.
How to manage it, with or without antibiotics, the prognosis, and those really important potential complications.
Yeah, by focusing on pulling out those specific details from your source material, framing them for easy recall, this deep dive should give you a really solid, high-yield summary for revision.
It takes the structure right from your notes and hopefully makes that key information just pop out a bit more.
Thinking about that core timing concept, that 10-day mark, it really is the thread running through everything, isn't it?
It absolutely is. It links diagnosis, when to investigate, when to treat.
Yeah.
It's probably the single most practical piece of info to take away.
So here's something to think about based on everything in your notes. Considering how many cases start viral and might just get better on their own.
Yet balancing that against the potential, even if rare, for those really serious bacterial complications.
How does that tension shape your clinical judgment about when antibiotics are truly necessary?
Yeah, that balance, guided by those timing criteria and severity, is really the art of managing this condition well. It's a critical judgment call.
Absolutely. It's all about getting that assessment right. Well, if you found this deep dive into your revision notes useful, keep digging into your study materials.
And if you're looking for more comprehensive resources to help you smash the MSRA and other exams, you can find loads of materials over at passthinksra.com.
That's PASSTHEMSRA.com.
And for some great free resources to kickstart your revision, check out freemsra.com.
We really hope this session has helped make your notes on acute bacterial sinusitis feel clearer and much more memorable for your upcoming revision.
Yeah, thanks for bringing your source material for this deep dive. Keep up the hard work, and we'll be here to help you unpack the next set of notes whenever you need.